Okay. Well, welcome everybody. All of you are out there. Unfortunately, I can't see many of you, so I'm assuming there are a bunch of people out there. Thanks for joining the meeting. Unfortunately, I'd hoped a few months ago when we planned this that we'd be able to do this together in person, but as you know, things have been different lately. So, and that's the reason why we're here, I guess, to talk a little bit about COVID-19 specifically and its effect on the heart and how heart disease interacts with the viral infection and what we've learned over the past really 2 years now. It's been just about 2 years, probably the first reports of this variant of coronavirus started back in November, December of 2019. And as everybody here is well aware, we really didn't get the full flavor of it until a little later in the early spring in March. But back in December and January, as it was starting to spread throughout China and Europe, we actually benefit from some of the experiences that they had, and were able to incorporate that into some of what we did. Period. I thought we would start with just a little bit of a historical perspective, specifically related to Greenwich Hospital's experience, and it would be really specifically related to Greenwich Hospital's experience in the Yale system. A lot of the obviously every hospital, certainly in the country and probably worldwide, has had an experience, and maybe people's experiences have been different. But ours was interesting, and that we were, one of the earlier locations really that had a large boom, probably right around the middle of March. It was right around March, right around St. Patrick's Day, around March 17th. And it really was a very rapid progression. It's funny, I remember the day that I was sitting up on the telemetry ward, and there was a nurse that came up from downstairs and said, well, we have a patient coming up who's intubated, and it looks like they have coronavirus. And somebody remarked, well, I guess it's real. And then from then on, things really just blossomed. And within that first week or two, we really changed the way we practiced. We were inundated with many patients, and had to really start converting medical wards to ICU wards, and ambulatory wards to medical wards, and the hospital and the system really leaped into action to do the appropriate changes and make the appropriate changes and make the appropriate facilities and so on. So that was how it started. We learned over time during that period that the coronavirus, the COVID-19 specifically, is really allows us to kind of learn about everything. There's used to, in medicine, there was a saying or sort of an idea that, you will learn medicine through, and you name it. So at one point it was through tuberculosis, and at one point it was syphilis. And when I was training back in the early 90s, it was through HIV. And what that means is that when you have a disease process that really affects every organ system in the body, that's how you learn. That's how you will learn about the disease processes that can occur, and the heart is no exception. When we first started to think about how the COVID infections were going to affect the heart, we were postulating various conditions that might even have long-lasting effects, and that might have consequences going forward. We've seen some of that, but to be honest, we haven't seen as much of it as I think we feared. I think that the effect of coronavirus, specifically COVID-19, on the heart is really quite widespread, and we're going to touch on those things as we go. explain both how that's the case, and of course the other part of it is how patients with heart disease are affected by COVID. So in pre-existing conditions, the patients that are most affected are in fact the ones that you know about, the same ones that you hear about on television. It's patients who are elderly, and that really does increase with age. So it's a continuum. And so the potential for negative outcomes and so on increases with age. When you add on things such as congestive heart failure and coronary artery disease, and specifically diabetes is also a significant risk factor. Those conditions are predisposing for worsening or a worse disease process, I should say. I'm sorry. So if we talk about what kind of manifestations we see specifically related as it is related to the heart, one of the things that we have noted is that we will sometimes see what we call elevated cardiac biomarkers, and that is specifically there are certain cardiac enzymes that we follow. These are the same enzymes that we follow for things like cardiomyopathies and heart attacks or myocardial infarctions. We noted that, in fact, patients had elevated troponins at times, even without specific indication that there was something going on from a cardiac point of view. So as far as a strain on the heart with relation to the infection, sometimes, as a function of the disease itself, sometimes as a function of the symptoms of the disease, such as low oxygen levels and so on. Other markers that are elevated in severe disease and to some extent in all levels of disease, but to obviously the greater levels in sicker patients would be other inflammatory markers. So there's a blood test called a D-dimer and a CRP, sed rate. These are all potentially elevated as well. And we learned kind of early on that these markers could be used to help us really understand which patients were going to potentially have more difficult courses and potentially worse outcomes. The D-dimer specifically is an interesting marker. This is a marker that we use for blood clotting, and we have seen that this has been elevated in patients that have significant COVID infections, and even in some patients who have recovered. Otherwise, the symptoms of COVID, cardiac-related COVID disease, really are the symptoms that are in most cardiac diseases. So chest pain, right, is the most common thing that we hear about. Palpitations, or what we talk about, heart racing, shortness of breath. So pretty much the symptoms are really not that different from other conditions. And unfortunately, a lot of these symptoms could be present in non-cardiac disease and non-cardiac components of COVID infection as well. So one of the big, issues with regard to COVID infection is lung disease and inflammation in the lungs and scarring of the lungs, which then also ultimately leads to hypoxia, which means low oxygen levels. These are common things that lead to a subjective shortness of breath, or what we call dyspnea. Palpitations or heart racing or regular heart rates can come not necessarily just related to the heart itself, but as a function of elevated catecholamine or adrenaline levels, also in response to low oxygen levels, in response to pain or anxiety, which was a big component of especially the patients who were particularly ill. I think that unfortunately the emotional toll of not only coming down with this illness and being aware that it could potentially be life-threatening, especially with if you knew that you had higher risk. A lot of our patients would have had people that they knew who had a bad outcome, and so unfortunately, going into this with that emotional strain will lead to things like obviously palpitation, shortness of breath, the subjective feeling of doom, if you will, chest pain, and so on. This was not this certainly was not improved by the fact that most of the patients obviously were in significant isolation. We had, because of an attempt to try to isolate the virus and not have it spread throughout, everybody who entered the room was wearing a full gear, not only a gown but a face shield and a mask, and it was hard to communicate with one another. Unfortunately, visitation was a limited thing because of the goal to avoid spreading to patients outside, to people outside. Very isolating condition and very sad. And so all of these symptoms kind of come together, and although we always look at symptoms with regard to what could be the underlying direct cause. So chest pain, obviously, we want to make sure that the patient is not having a heart attack at the time, is not having a myocardial infarction, is not having blockages in their blood vessels that could be causing causing the chest pain, because there were real conditions as well that were directly affecting the heart. As far as what we would call like the objective clinical syndromes, so the conditions that are a direct effect of the heart and on the heart. Myocarditis is something that we've talked a lot about with regard to COVID, and actually now with COVID vaccines. Myocarditis just basically means an inflammation in the heart. The same way you would get sinusitis and you get an inflammation in the sinuses, and what does that do? It causes swelling, it causes fluid drainage, and so on. It's the same thing that happens in the heart, and in the heart you can get myocarditis in a more diffuse way throughout the heart, or you can get it more in a more localized way. If myocarditis is a significant condition, it generally presents with a rapid heartbeat, elevated biomarkers like the troponin levels, and then ultimately can lead to cardiac dysfunction. It can lead to what we call a cardiomyopathy, or a weakening of the heart muscle. It's actually pretty uncommon, and I will say that even within the setting of COVID, it's been hard to really kind of pin a lot of this, at least from our experience, on COVID itself. There has been very limited data showing biopsy-proven myocarditis. Now, that being said, biopsies for myocarditis are not as common, but even certain studies with regard to younger patients who recover from this, doing different kinds of investigative testing, such as cardiac MRIs and so on, the prevalence is not quite as high as we thought it might be. So most of the patients that you would see with this kind of thing who have a weakening in the heart muscle, who might actually have an improvement, could also have a variant of what's called a stress cardiomyopathy. Stress cardiomyopathies, or there's sometimes where we refer to them as a Takotsubo cardiomyopathy, when it has a specific pattern to it, is a weakening of the heart that does not have a particular concrete etiology or cause for it. We don't have a great understanding of it, actually. We know that it happens, we know that it can get better, we know that it has something to do with a catecholamine or adrenaline surge in the body, but the specifics of why some people get it and some people don't is unclear. Certainly stress cardiomyopathy is a significant component here, because it's, when we say stress, we don't just mean emotional stress, although that's part of it. What we mean is a kind of a stress on your system. So when somebody has a bad COVID infection and they are seriously hypoxic. Their oxygen levels are very low. They are struggling to breathe, whether they're ventilated at that point. And then on top of that, the body fighting whatever other super infections and so on, which can come along with this. So a stress cardiomyopathy is certainly a possibility. The other thing we can see objectively is a change in the right ventricle, which is usually a function of pulmonary embolism and strain on the right ventricle of the heart due to blood clotting that goes into the lungs, and we'll talk a little bit more about that in a little bit. Arrhythmia. Patients, when you're in the hospital and you're sick for any reason, it's not that uncommon for that to be an environment where a condition called atrial fibrillation could occur. And so we did see a decent amount of atrial fibrillation in the hospital. When I look at it objectively, to be honest, I'm not sure that the prevalence of the atrial fibrillation was any more than we would see in any other critically ill population. So if you, obviously we would be seeing less of them at any given time, but if a patient had a bacterial infection throughout their body, or if somebody had a severe, a bad outcome in surgery, or they had bleeding or something like that, that kind of environment does make the likelihood of atrial fibrillation greater. And so we saw, in keeping with that, we saw the same thing in the setting of people who had severe COVID infections. In addition to that, one of the arrhythmias that I've noticed in some patients after a COVID infection, and mostly in patients who really have had a recovered COVID infection, is something called POTS, or postural orthostatic tachycardia syndrome. POTS is a condition where when you start to move, you get up and start to move or stand or whatever, that the heart rate tends to increase beyond what it needs to. And it really has to do with a dysfunction of the autonomic nervous system, which basically controls the adrenaline and the and what we call the vagal system, which is the opposite of that, the sympathetic and the parasympathetic nervous systems, which are constant competition. And so illness can throw that off. And we see this condition, and we often will attribute it to viral infection, generally viral infection, not necessarily just COVID. So, but when you have a situation where you have so much viral infection throughout society, then of course you're going to see an increase in this, in the prevalence of this. Bradycardia means a slow heart rate, and we've seen that as well, sometimes related to, again, low oxygen levels. There's been some suspicion that bradycardia could be a result of one of the drugs that we use in COVID infection called remdesivir, which you may have heard of. It's really the first of the therapeutics that was truly approved. And so we see that, and generally it's been a fairly benign condition, and it improves with medical treatment. So some of the more serious things that we saw in the hospital, especially kind of leading up to COVID and leading up to our kind of understanding of it from early March, or I should say middle of March through, let's say late April, early May. We did have a few patients that came in with somewhat unexplained myocardial infarction or heart attacks, and which ultimately we felt were probably related to coronary thrombosis or blood clotting within the heart vessels. And actually, there were some very challenging cases that my colleagues in the interventional cardiology world had to deal with. And some of it was because of the inflammatory markers and the inflammation in the COVID infected patients. Blood clotting was just very significant. And so it was very hard to manage the way we would normally manage a myocardial infarction. Usually a myocardial infarction is related to a very specific portion of the blood vessel, and when seen early, the patient can have what's called an angioplasty, and they can put in a stent, which is like a little device that opens up the blood vessels. We treat patients with blood thinners in that setting, and they generally get better, when they're treated early. In the COVID infected patients, specifically the sick COVID patients, those who had really elevated inflammatory markers and who really had these storms of cytokine storms, this really high level of inflammation, sometimes the clotting would sort of outweigh our ability to challenge it with blood thinners. And so those were very challenging cases. Interestingly enough, there were, in our experience, there were a few of these cases early on, and then we really didn't see that again afterwards. And so I don't know if the early stages of this condition and maybe the exposure because of, before people really were on guard and being cautious and not really exposing themselves to other people and so on, it seemed like a lot of these were more prevalent early on. Interestingly enough, worldwide, the statistics on hospitalizations and interventions for acute coronary syndrome actually went down quite a bit during the COVID infection. And in fact, a lot of the things that we see very regularly, I specialize in arrhythmias and I implant pacemakers. And I would say that the number of patients that presented with a need for a pacemaker in that 3-month period was significantly reduced from before. And of course, some of that is observation, some of that is participation bias. So people were not coming to the hospital in spite of some symptoms that they might have come earlier. And they were sitting at home and kind of writing it out, hoping for the best. But even with that, the overall numbers had declined, and it's a little hard to really know why. I think everybody's kind of thought about it, and there's been some theories put forward, but it was unclear how a lot of the things that we do on a day-to-day basis and up until March of 2019 were very routine things that we saw all the time in the emergency room and in the offices, and complaints, from just, routine physicals, things like that, just kind of went into the background. So it was interesting. And certainly after the first storm of that in the spring of 2020, in the follow-up in the summer of 2020, we certainly did see a little bit of a rebound in some of that, things that then presented themselves that we were obviously not seeing during that time. But that is that was definitely something we had seen that we saw that was concerning, was this very thrombotic state. And in fact, other conditions as well with regard to blood clotting were important. And then, of course, just exacerbation of pre-existing cardiac disease. So if somebody has congestive heart failure, and, patients who have congestive heart failure sometimes require a lot of interaction with their cardiology practice, with their heart failure management doctors or their cardiologists and so on. And, there are patients we sometimes have to see, almost on a weekly to bi-weekly basis. And, in order to really kind of maintain fluid management and so on. And a lot of that really was hard to do in this setting. Patients were afraid to come into the hospital. There were certainly some limitations with regard to who we could take in the hospital. We were trying to, limit that exposure, at least early on. And so obviously if somebody has a tenuous cardiovascular system, and then you add on to that the infection from COVID-19, that can potentially affect the the way the lungs take up oxygen and the way the body manages its blood clotting, et cetera, that's going to make things worse. And this is why, certainly why a good reason why why patients with cardiovascular disease are at a higher risk of bad outcomes in COVID-19. Thrombotic complications, which basically means blood clotting, were probably some of the more impressive things that we saw during the time. I mentioned before about myocardial infarctions and how some of them really presented very demanding cases where trying to battle the clotting while allowing for reperfusion was very difficult. Pulmonary embolism and deep vein thrombosis, what that basically means is that blood clots in the veins, generally in the legs, which could then travel through the veins up into the lungs, and that's called a pulmonary embolism, were not uncommon in the sicker patients. And in fact, one of the things that we learned really in this setting of COVID, and probably one of the most important interventions that we made, because, we did a lot trying to treat COVID. We tried different medications initially. We tried anti-inflammatory medications. We tried different versions of steroids. We tried antiviral medications that were targeted towards other viruses and certain other immune modulating drugs, cocktails of medications and so on. And probably one of the most significant interventions we did, or maybe the most significant intervention, was discovering that in fact thrombotic events and blood clotting was so important in treating this disease. And so supportive care and anticoagulation probably was the most important intervention we made, at least in the first 6 months or so. Afterwards, there were other treatments that became a little more clear with regard to dexamethasone steroids and remdesivir, which is an antiviral that was kind of developed in this setting, as well as some of the plasma treatments and so on that were somewhat helpful. But early on, to be honest, it really was mainly the main benefit was just trying to prevent blood clots. And in that realm, by the way, strokes were also part of this, process. Overall, interestingly enough, though, the COVID proven, etiology of cardiovascular events was really very difficult to define. As I said, a lot of what we saw was really a function of the illness itself and its effect on the heart. So as opposed to specifically the virus's effect on the heart itself or the vascular system, except for, of course, thrombotic disease and blood clotting, which is which was obviously very important. And even going forward and looking at these things in retrospect, it's been very hard to really kind of connect those two things, which in a way maybe is a good thing. I think that what we see is that the incidence of the things that we worried about, how is it going to affect people long term? Were we going to have an overabundance of young people who got this infection and then, 2 years later, the heart failure clinics are overrun because there's so many patients that have end-stage heart disease and so on. So far, I don't believe we've seen that. There have been cases of it. And I think, like a lot of viral illnesses, as I mentioned before, a lot of the things that I talked about, myocarditis, cardiomyopathies, things like sympathetic abnormalities like POTS syndrome and so on, are things that we've always traditionally, when we've seen them, have said it's probably related to a virus. And there is a family, various families of viruses that we've identified as causing these things. And I think the only difference with COVID in some regards is that there just was so much of it at one time. And so obviously the, seeing it was very, was more common. As far as other things related to this, one of the things that actually took a lot of our time and energy um, in early on in COVID was the treatment. One of the mainstays of treatment that we had initially, at least had an indication of use, was using hydroxychloroquine, which you may have, I'm sure everyone has heard of, or Plaquenil. It's a very common drug. It's something that's been used for years, and it seemed to be something that could potentially be beneficial. That, along with drugs like azithromycin and some of the antiviral medications and so on, unfortunately all had the one of the side effects of all of them was their effect on the EKG, or something we call the QT interval, which is a measurement that we do on the EKG. And when the QT measurement becomes very prolonged, it can make you prone to certain kinds of arrhythmias. So a lot of our energies early on, at least from a cardiologist point of view, a lot of my day back then was spent really screening these EKGs and monitoring patients on the telemetry to really see what the effects of these medications were. We actually were able to use some of the data, and we published some of that data as well. And luckily, we didn't, again, see the kind of impact that we were concerned about. We developed strategies to manage the medications in such a way where when we thought things were going in the wrong direction, we would back off on the medications and then be able to sort of manage that. We learned, early on how to deal with that, and but we did put a lot of energy into it. Again, as a cardiologist, caring for patients in the hospital during that time, I would say that most of what we were dealing with was the kind of things that we would deal with in any population that happens to be in the hospital and sick. An increased incidence of arrhythmias like atrial fibrillation, management of blood pressure, management of ill-defined cardiac symptoms, and trying to sort out whether those things were related to the viral infection or to the ventilators that people were on, or infections, or antibiotics that were being used in addition to that, and really just kind of the same stuff that we did all other times. So as far as how all of these things pertain to the vaccines, because that sort of is the hotter topic now. The probably myocarditis is the one that people have talked about the most. There is an incidence of a variant myocarditis that we see with the mRNA vaccine, specifically, I think the Pfizer vaccine, because that was the one that was studied more in the younger patients, and and it's been seen in younger males. So basically, boys between, I think, 13 and 18 or something, where they could get this. Now, the good news about it is that it appears that this seems to be transient. It doesn't seem to have any long-lasting effects, and so in general, children do well in spite of that. Arrhythmias are very interesting as well. We talked a little bit about atrial fibrillation before. I will say that I've had, as I see a lot of patients who have arrhythmias, specifically atrial fibrillation, I've had a good number of patients who have had arrhythmias that have coincided with their vaccine. And it's hard to know for sure whether, in fact, the vaccine had anything to do with it. And the reason why I say that is because when you think about the fact that the majority of the patients who got vaccines got the mRNA vaccine, so they were getting 2 shots, basically. So you take all of those people and you expose and you distribute 2 shots among them, and then you say, okay, how many people have arrhythmias? Is that different than if they didn't have the 2 shots, would they have still had the arrhythmias? And it's hard to know. I don't know that we know the answer. A lot of this is really kind of still a little bit up in the air. I know for me, a lot of my patients that had the arrhythmias in relation to the shot, many of them I would have said I wouldn't have been necessarily surprised if they had the arrhythmia anyway, because they had, they had a propensity toward that and they've had them before and so on. But then I've had some times where patients have had it, and I really do say, boy, it seems to be, in relation. We don't have any idea as to what the mechanism of that would be. I think arrhythmias in general tend to find people who are having trouble of some other kind, whether it's an infection or it's other medical condition and so on, and they tend to crop up in that regard. And then thrombosis, and that's also something that has been, luckily, most of these things have been generally on what we would call like a case report level, meaning that they're not very common. They're actually fairly uncommon. Things like neurologic conditions like Guillain-Barré and so on. We see that in just about every vaccine. The difference with this is obviously it's a newer thing. It's much more publicized. There's much more, general societal controversy about it. So it's, that's what makes it different. But honestly, it probably, when at the end of the day, when we go back and look at all this, it's going to show us that the vaccines have sort of a similar outcome to any other vaccine. But that obviously remains to be seen. And so, I guess in closing, for my presentation anyway, what I would say is that, COVID, like a lot of diseases that society has dealt with over the years, affects really throughout the whole human body, and so because of that, it allows us to really learn about disease processes in a new way. And I think that the same way I learned a lot back in the early 90s with patients who had HIV, and discovering how different organ systems will behave that way. I'm sure that the people who live through this, and especially people who are training in medicine and so on, are always going to look back at that as how they learned about things like myocarditis, or they learned about things like pulmonary fibrosis, or whatever the condition is. So I hope we've learned a lot, and I think that we've shed some light on this condition and how it affects not only the heart but other organs, and hopefully we won't have to deal with it as much in the near future. So I have to say I don't really know exactly how to bring up questions, but I'm happy to answer questions.
If you have any questions, you can use the Q&A feature on your toolbar of the Zoom. Just move your cursor down to the bottom. You can type in questions there, and the doctor can bring them up.
And I will, while we're waiting, I will tell you, I apologize if this was a little bit maybe a little dull. It's a little hard to really kind of present it in this format, I think, and but I hope it was at least worth your while. I don't actually see any questions coming up.
Question just came up.
Yep, now I see a question. Okay, so this question was if I've encouraged my patients to get vaccines, or are there certain conditions where we would discourage them? I've encouraged them really from the beginning. Part of that is because so many of my patients fall into, almost by definition, if you're my patient, you probably fall into the category of a high-risk patient. Even something as simple as hypertension. But I do certainly have a population that is in the older demographic, many of which have coronary disease, many of which have a coexisting pulmonary disease, and diabetes, of course, which is very common. And so I encouraged my patients from a very early time. And I have to say that overwhelmingly, I feel that the majority of my patients have done very well with vaccines. I'm really not aware of any major downside. I certainly encourage my parents, who are both at higher risk, to go ahead and get the vaccines as soon as they were able to do that. I'm certainly going along with the recommendations currently for the booster, especially in the high risk, in high risk patients. It doesn't seem to have been causing any particular side effects at this time. There's nobody in particular other than the patients who may have had a bad reaction to, let's say, one shot. So if they got the first of their Pfizer or Moderna shots and they didn't do well with that, then maybe you would tell them not to get the second one. There was a little bit of concern initially about things like anaphylaxis, people who have a history of bad allergies and being a little more cautious. I think that in some patients, what I recommend is, if there's a little higher concern about that, maybe get your shot at a medical center or at a health fair that is being run by a hospital. We've had that. Some of the other local hospitals have had that. Not that the shot isn't just as good from CVS or Walgreens or whatever, but maybe just a little bit higher level of comfort that there's a little more medical backup around. But in general, I would say, I've mostly recommended the shot to all my patients. And so there's a follow-up of that, of whether we recommend the shot even if somebody has had COVID. So, I think that has to do with risk. I think it's hard to know exactly what, especially in somebody who is otherwise, because I think this kind of boils down to this debate of what the right thing to do is if you've had a proven infection. I think that somebody who has had, truly COVID positive, who was able to come through the infection and did fine, who has, reservations about taking a vaccination, I think that they certainly have a level of immunity. There are questions about the duration of immunity, but there's questions about the duration of the immunity of the vaccine as well. And I think that is the case. I probably would have maybe done things a little different as far as recommending to people who have had the infection early on. I think that early on we might have been able to distribute that vaccine a little bit more efficiently. If we said, okay, if you've had a COVID proven, a proven swab proven infection and you've gotten through it, wait, until later on. I think that could have helped just from a logistical point of view. But as of now, I think that if you feel comfortable doing it, then I think that the recommendation is that you go ahead and do it, and that you get the booster. But if you don't, not the booster, the vaccination. So that's kind of how I do it. I think that it's a discussion, patient by patient, what their response has been, how they feel about, the process. And I think that's really, important. Okay. All right. Well, I don't see any other questions up there. Okay. Well, I guess I'll just thank everybody for joining us. Hopefully, some point we can do something like this again in person, which I think will be a little more dynamic. But I think I guess we'll adjourn. Does that sound okay, Diane?
Okay, then I'll stop the recording and exit out for everybody.
Thank you. Okay, thank you, everybody.